Hi, my name is Tracy Wang. I'm an attending cardiologist in the CCU, and today we're going to talk about STEMI and non-STEMI management in the ICU. Specifically, we're going to talk about the timing of angiography, anticoagulant selection and use in the CCU setting, antiplatelets, as well as other long-term treatments. Just for background, we know that there are about 1.2 million hospital admissions for acute coronary syndrome every year in the United States. About a third of these are ST elevation myocardial infarctions, and about 2/3 of these are non-ST elevation acute coronary syndrome, which includes non-STEMI and unstable angina. Just a quick reminder about the pathophysiology of this. For STEMI, as you can see on the left, there's a complete occlusion of that coronary vessel. That means blood can go beyond that level of occlusion, and so all the cells beyond that are having issues. For non-ST elevation acute coronary syndrome, there is typically a significant blockage in there that prevents efficient blood flow, but some blood is going through, and so the degree of damage depends on how restrictive that blood flow is, with MIs resulting in myocardial damage, whereas unstable angina is basically a sign of myocardial ischemia. So when we talk about STEMI patients, the key issue is reperfusion. Reperfusion needs to be administered to all eligible patients as quickly as possible to improve blood flow, and ideally within 12 hours. In fact, the recent guidelines have changed so that for EMTs who are transporting patients, it's actually asking EMTs to try to get the patient to the hospital as quickly as possible to get PCI within 90 minutes from first medical contact. That means that if an EMT picks up a patient and has a choice of which hospital to go to, they're going to want to come to a hospital that is more likely to be able to do primary PCI for that patient. For non-ST elevation acute coronary syndrome, the timing of cath is a little bit more variable. The more recent guidelines divided this into 4 groups of patients in terms of how they think about invasive strategies. For the first group of patients, these are patients who are the sickest, who have refractory angina, signs or symptoms of heart failure or cardiogenic shock, other forms of hemodynamic instability or electrical instability. These are patients who need to go to the cath lab sooner rather than later. So you'll activate the cath lab typically within 2 hours of you meeting that patient. For other patients, we have a little bit more leeway in risk stratification. There's still that early invasive strategy. I'm going to talk a little bit about the GRACE risk score in the next couple of slides. But for patients who have very high GRACE risk score, which is indicative of high ACS risk, as well as those who have a temporal change in troponin, an increase and a fall in troponin, these are patients who you want to take to the cath lab as quickly as possible, but ideally within 24 hours. Let's talk a little bit about the GRACE risk score, or in fact any other risk score. Take a look at this graph. On the x-axis, you see the ranking of GRACE risk scores from low to high. And on the y-axis, on the right-hand side, you see that there's a green line for mortality here. The bars represent the proportion of patients who are troponin positive in yellow or troponin negative in blue. And the point of this slide is to basically say the troponin is really not enough. So as you can see from left to right, the mortality line goes up, which indicates the higher the GRACE risk score, the higher the risk of mortality. But when you look at the troponin distribution, you find some things. Even the patients who are at the highest risk on the right-hand side of the slide, there are still some troponin negative patients in there. Whereas on the left-hand side, among patients who have very, very low mortality, there are certainly quite a few patients there who are troponin positive. So the point of this is to say, in 2015, 2016, troponin alone is really not enough as a risk stratification measure. So you're going to ask yourself, well, why do I even need to think about predicting risk? Wouldn't I know how high risk the patient is? And perhaps that's true, but in this case, as you can see in this study, that was not true. When physicians were asked to evaluate their patients and categorize them in terms of low, intermediate, or high risk, and then we correlated that with the GRACE risk score, we found that there was really actually very little correlation between a physician's ability to predict risk and the actual GRACE risk score. Now we know that once a physician assesses a risk, the higher risk patients will be treated more aggressively. But what we want to do now is to make sure all of our high risk patients are treated aggressively. Now, in our CCU, why do we calculate risk scores? Well, one key reason for calculating a risk score is that it really allows us to assess the proper timing of PCI. This was the TIMAX trial. The TIMAX trial basically randomized patients to those who got PCI within 24 hours of their NST-ACS and those who got PCI beyond 24 hours. So as you can see, within the early group, which is in the gray bar, you will find that these patients went to cath within 24 hours, and actually they went to the cath lab with a mean of 15 hours. Okay. Now overall, the trial was relatively neutral. There was no difference. But when you did a secondary analysis of the data, you find that in patients who have a high GRACE risk score, this is the set of bars on the right-hand side, among those high-risk patients, early PCI was actually associated with a lower risk of adverse cardiovascular outcomes. So this is why we calculate a GRACE risk score. If we can use that to assess patients in terms of how high risk they are, that actually helps us change our treatment strategy to take these patients to the cath lab sooner. And if you have any questions about how to calculate a GRACE risk score, well, fortunately, this is something that is everywhere. You can Google this. There are apps for this. But basically, a GRACE risk score takes a number of the characteristics that you see on the left-hand side of the slide, puts it into a calculator, and then is able to tell you what the patient's in-hospital mortality is predicted to be, as well as what their 12-month mortality is predicted to be. And a lot of these risk scores, these tools, actually give you a sense for how this patient looks relative to other patients that are similar in age or sex. Let's shift gears a little bit and talk about anticoagulant therapy. And in this domain, it's really easy because guidelines basically say you can use any of the 4 anticoagulants that are currently available out there. So there's the classic unfractionated heparin, there's the enoxaparin or low molecular weight heparin, and there are alternatives that are relatively new such as bivalirudin or fondaparinux. All of these are available for use for patients with non-ST elevation acute coronary syndrome. And to a certain extent, their selection and their use are often driven by what is on the institutional formulary, what the hospital chooses to prefer to use. The only caveat I'm going to mention is that if you choose to use fondaparinux and then you send the patient to the cath lab, guidelines come out to say because there's a higher risk of catheter thrombosis for these patients, that the cath lab attending or fellow will need to supplement with another dose of either unfractionated heparin or bivalirudin to try to avoid that risk of catheter thrombosis. And honestly, here at Duke, I think we use fondaparinux relatively infrequently. So often the decision point is between unfractionated heparin or enoxaparin and bivalirudin. So I'm going to go over a quick trial, and this is the Acuity trial. This looked at non-ST elevation acute coronary syndrome, and the trial actually had 3 arms. A group of patients who were treated with heparin and a 2B3A inhibitor, a group of patients who were treated with bivalirudin and a 2B3A inhibitor, and a final group of patients who were treated with just bivalirudin. And the key comparison is actually going to be between the first group, that top group, and the bottom group. So unfractionated heparin and 2B3A inhibitors versus bivalirudin alone. This slide essentially summarizes this. And I'm going to have you focus on the middle set of bars here. When you look at ischemic outcomes, basically this Acuity trial said that there was absolutely no difference in outcomes between patients who were treated with heparin plus a 2B3 inhibitor versus just a bivalirudin infusion alone. But if you look at the third set of slides, what you see is that patients who just received one agent, and that agent was bivalirudin, those patients were much less likely to have bleeding complications than the patients who were treated with heparin and a 2B3 inhibitor. And so that really forms the basis for why we think about using something like bivalirudin. Bivalirudin is something that should be used in patients who are high risk for non-ST elevation acute coronary syndrome, but who are also high risk of bleeding. We want to be selective in their use. Why do we need to be selective? Because the price differential is pretty large. Okay? Typical bag of heparin can cost up to $10 for a 24-hour infusion, perhaps. A bag of bivalirudin can be 100 times that. Hopefully it'll be going generic soon. But that may be a reason why we shouldn't potentially be using bivalirudin in every single patient who comes in with a non-ST elevation acute coronary syndrome. Perhaps we should be reserving it for those patients who would really benefit because they're at high risk of bleeding. Now let's switch our focus a little bit to antiplatelets. Let's start with something really classic like aspirin. Would it surprise you to know that we don't know what the right dose of aspirin is to use in the ACS setting until 2010? We didn't know this until 2010. 2010 was when the current OASIS trial came out, and this randomized patients to either a low-dose aspirin or a high-dose aspirin. And as you can see here on the slide, there was virtually no difference between patients who were treated with low-dose versus high-dose aspirin. So less is more. In our CCU, we'll give patients their first dose as a full dose, and then every subsequent dose after that, we use a baby dose aspirin. Let's talk about clopidogrel. Now, clopidogrel came on the map in the early 2000s, actually in the late 1990s, and the CURE trial was the classic trial that looked at this in non-ST elevation acute coronary syndrome, where everyone got treated with aspirin. Half of these patients got clopidogrel and the other half got placebo. And as you can see on this slide here, use of clopidogrel was associated with a 20% risk reduction. So this is why clopidogrel is part of our guidelines. This is a drug that's clearly effective in reducing the risk of major adverse cardiovascular events. Now, one of the problems with clopidogrel is if I gave 100 people clopidogrel and I watched them take it faithfully every single day for a week, and then I drew blood from them to look at how well they're responding to the therapy, I'm going to find that approximately a third of these patients will be as if they've never taken the drug at all. And that's because there's a heterogeneous response to clopidogrel, mostly driven by the fact that clopidogrel, as you remember, requires a two-step activation metabolically in order to become an active drug form. And that's primarily the basis for why some of the novel antiplatelets have been developed. These novel antiplatelets are not only stronger, and that means more people will respond to the drug as opposed to 2/3 with clopidogrel, but they also have a faster onset of action. So the first one out of the gate was prasugrel. When prasugrel was compared head-to-head against clopidogrel, and this is in the Triton trial that looked primarily at PCI-treated patients with acute coronary syndrome, we again see that prasugrel provided an almost 20% further risk reduction compared with clopidogrel. But that came at a price. What you see on the bottom two curves of the slide is that when you use a stronger antiplatelet agent, you're more likely to get bleeding. And we did see a 30% increase in bleeding associated with that higher potency drug use. And in particular, the FDA has a warning on this. So for patients who've had prior stroke or TIA, the risk of intracranial bleeding far, far outweighs any potential benefit of prasugrel. So this is a black box warning, which means anytime you see prasugrel on your medication list for your patient, the next thing your eyes should drift over to is the problem list to find out if the patient has had a prior stroke or a prior TIA. If they have, then you really need to say, well, I need to get prasugrel off the medication list because the FDA tells me that I should not be using this drug in this particular patient. Now, the FDA also mentions two groups that they call cautionary use. And this is for patients who are over 75 years of age or patients who have a very low body weight below 60 kilograms. What cautionary use basically means is that you better have a really good reason for wanting to use this drug in these two types of patients. And really, the data have shown that there are two groups of patients who potentially warrant therapy that are with prasugrel that should be considered. These are the STEMI patients and the diabetic patients. But in these two scenarios, basically, you need to ask yourself, is the potential benefit of the drug higher than the potential risk of bleeding from the drug? And if the answer is yes, then prasugrel should be used in that particular patient. Another alternative antiplatelet therapy that's come out is ticagrelor. and this was studied in the Plato trial. And as you can see, the curves here are very similar to previous trials, where when you compare ticagrelor against clopidogrel, you find that patients treated with ticagrelor do better. They have about a 16% risk reduction compared with clopidogrel. And Plato was actually a pretty large trial that looked at both patients who underwent PCI, so underwent invasive management, as well as older patients perhaps, or those who basically the clinician decided there's no need to cath a patient, so non-invasively treated. And as you can see from the two sets of curves here, the relationship is essentially the same regardless of whether or not a patient was invasively or non-invasively managed, meaning ticagrelor did better regardless of whether or not you cathed the patient. So you can use this patient, unlike prasugrel, you can use this patient for both your PCI treated patients as well as your non-PCI treated patients. In many ways, you're going to see that if you use a stronger antiplatelet agent, you should see more bleeding. We see the same thing with ticagrelor here. The caveat is the right-hand side, two sets of bars there. For patients who ultimately undergo cath, and then you find out that you need to put this patient through cabbage surgery, these patients actually, when they're treated with ticagrelor, do not seem to have a higher bleeding risk than the patients treated with clopidogrel. And that has to do with the fact that ticagrelor is a twice-a-day drug, BID. So that means the half-life is shorter, which means that a lot more of the drug has left the system after you've held it for 5 days for surgery. So that may be the reason why ticagrelor-treated patients don't have much higher cabbage-related bleeding than clopidogrel-treated patients. Now, another take-home lesson for residents treating patients with ticagrelor: if you see ticagrelor on your med list, the next thing your eyes should move over to is further up or down on the med list to see what the aspirin dose was. Because this was a secondary analysis from Plato that seemed to suggest that ticagrelor only worked when it was matched up against the baby dose of aspirin. And in fact, the FDA also put this in their formal prescribing information form that basically says, if you're using ticagrelor, make sure your aspirin is at a low dose. In the US, that's 81 milligrams. The recent guidelines have changed because, as you've seen, we now have lots of options. We can use clopidogrel, we can use prasugrel, we can use ticagrelor. The recent guidelines have changed to say if you have a patient who's going for PCI, you should try to pick either one of those stronger antiplatelet agents in preference to clopidogrel. And that's based on the data that I've just showed you that says these two agents do better for the patients than clopidogrel. Obviously, if a patient's not a candidate for either one of those drugs, then clopidogrel is still a perfectly good choice. And so what's our algorithm here at Duke? Well, if we're trying to give the patient a dose of the P2Y12 before cath, then we really have two choices. Ticagrelor is the preferred choice. Clopidogrel is a reasonable choice for patients who are not candidates for ticagrelor. Notice that if you're administrating a P2Y12 before cath, prasugrel is not on your list of options here because prasugrel was only studied and shown to be beneficial in PCI-treated patients, so after cath. Now, after you've decided which P2Y12 agent you're going to give the patient, then you kind of go down the algorithm in terms of whether or not the patient's going to cath or not going to cath, and whether or not the cath is going to be occurring early versus later on. Typically, most of our patients go to the cath lab within 24 hours. And in that case, either unfractionated heparin or bivalirudin would be your anticoagulant of choice. And this is where, again, you're going to need to think about, is my patient at a high risk of bleeding? Because if they are, bivalirudin may be the better option. If their risk of bleeding is really not that high, pure, plain old unfractionated heparin works just as well. Okay. If the patient's going to wait a little while before they go to the cath lab, or you just decide, I am not planning to cath this patient for whatever reason, then bivalirudin really should come off your list of options because that's really reserved for patients who are going to the cath lab sooner rather than later. In this case, you can think about unfractionated heparin, enoxaparin, or fondaparinux, and it's dealer's choice which one you'd like to do. On the right-hand side of the slide, these are for those unstable angina patients, the patients that do not have positive biomarkers and are lower risk compared with the MI patients. Here, your anticoagulant choices are either fondaparinux or unfractionated heparin, depending on when you think if you think or when you think you're going to cath the patient. Now, a few special things that I want to talk about. When you're thinking about how to treat patients, a lot of what I've told you about has been trying to balance that ischemic benefit versus the bleeding risk. And so you might be wondering, why do we care so much about bleeding? Well, this slide really says it all. This basically takes patients who have had an acute coronary syndrome and classifies those into those who had no bleeding, mild bleeding, moderate severity of bleeding, or severe severity of bleeding, and then looked at their death rates all the way out to about 3 years after their acute coronary syndrome. And I guess it's not really a surprise here. If the patient bleeds more, they're likely to do worse over time. This is why we are so concerned about bleeding. If we can avoid the bleeding up front, then hopefully the patient is going to do better over the long term. And so how do we avoid bleeding? Well, part of it relates to drug selection, but I do want to highlight human error as a potential thing that we can avoid. This is a great study that one of our other attendings did in 2005 that basically surveyed almost 400 hospitals across the United States and simply looked at how we dosed the medication. And in particular, looked at how we dosed anticoagulants, so unfractionated heparin, low molecular weight heparin, and 2B3 inhibitors. And shockingly, we found that up to a third of patients were receiving the medication at the wrong dose. In fact, they were receiving too high of a dose of that medication. If you just looked at either heparin or 2B3 inhibitor excess dosing, as you can see in the red bar, 42% of patients were getting too much drug. Is that a problem? Yes, it is. So now if we divide a patient into those that were properly dosed in the white bar versus the ones that got excess dosing in the blue bar, and then we looked at their transfusion rates, it's really not surprising to see that if patients got too much drug, they were more likely to bleed, and they were more likely to bleed to the extent where a clinician was obligated to now transfuse the patient. Obviously, we want to avoid transfusions if we can. Are there particular patients who are more likely to get excess dosing? Yes. So these are the groups I want you to pay attention to when you're dosing medications. Women. Women are more likely to get excess dosing, probably because we're not always estimating their body weights well enough to do dosing for things like unfractionated heparin, for example. Patients who are older, these are patients who are more likely to get excess dosing. And again, it may be a combination of the weight, or it may be because they have lower renal clearance. And as you can see on the last set of slides on the right, if patients have a lower creatinine, really it should be lower creatinine clearance, which takes into consideration their weight, these are patients who are more likely to get excess dosing than patients who have a lower creatinine. Actually, I just looked at the slide and I realized I switched the labels on the last two slides. Please switch them back around. Now, after the acute coronary syndrome setting, what we find out is, in this REACH registry, is their risk of major adverse cardiovascular events extend way out beyond just the acute period. So REACH looked at them all the way out to 4 years and found on the first two bars on the left-hand side of the slide that if a patient has had an ischemic event, regardless of whether it's within a year or more than a year out, these patients are always still going to be at higher risk of a cardiovascular death, an MI, or a stroke, compared with those who've never had an acute ischemic event or who just have risk factors for coronary disease. So that means that we really need to be very aggressive about risk reduction, not just in the acute CCU period, but post-discharge as well. And one of the changes that's come across in guidelines recently is how aggressively we want to manage their cholesterol levels. So if someone has had clinical atherosclerotic cardiovascular disease, and certainly ACS is one of those conditions, the recommendation is to use as high of a dose of statin as the patient can tolerate. For patients who are under 75 years of age, a high-intensity statin is recommended. And by high intensity, we're talking about a statin that can reduce the LDL level by more than 50%, which essentially means 2 drugs, 2 doses. Atorvastatin or rosuvastatin. For atorvastatin, it needs to be 40 milligrams or higher. For rosuvastatin, it needs to be 20 milligrams or higher. Patients should be on either one of these drugs at the doses that are described here if they can tolerate it. If they can't, then I guess you can go for a lower dose. For patients who are over 75, you get a little bit of a pass. Again, you want to be aggressive about lowering their statin, but perhaps not that aggressive, so a moderate intensity statin would be fine here. Other therapies that we see commonly in the CCU, beta blockers and ACE inhibitors. We try to get those started on patients as early as possible. For beta blockers, the recommendation is that after 3 years of treatment post-MI, we take another look at the patient. If the patient has a reduced ejection fraction, less than 40%, or signs or symptoms of heart failure, these are patients who we probably want to continue beta blockers long-term, practically for the rest of their life. For ACE inhibitors, the patients with diabetes, the patients with chronic kidney disease, hypertension, diabetes, heart failure, reduced ejection fraction, these are patients who probably need to be married to an ACE inhibitor or an ARB if they can't tolerate an ACE inhibitor for the rest of their life. Finally, even though you're in the CCU and you're just treating the patient for the first 24, 48 hours of the patient's MI course, keep in mind that for the patient, this is going to be a lifelong disease process that they're going to need to treat, and they're going to need to be very good about follow-up, adhering to their medication, adhering to a particular set of lifestyle changes. So it's always good to start emphasizing that early on. Now, I've got some shocking statistics shown on this slide here. MI patients, when you look at them after they've discharged from the hospital, about 1 in 5 of these patients don't actually go to the pharmacy to pick up their prescriptions. And even if they did go to the pharmacy and pick up their prescriptions, almost half of these patients aren't taking the medications the way we'd like them to be taking the medication. All of this results in more than $100 billion of unavoidable healthcare costs that really can be prevented. And this is not just a problem in our cardiology population. So this again brings up the point that when we can, we should emphasize patient education, emphasize the severity of their disease, and emphasize the need for lifelong medication use and adherence very early on in their MI course. My last slide shows some of the recommendations that I often talk to patients about before I discharge the patient, when they're a captive audience on my service, and I know I've got their attention and I need to talk to them about these things. And then I re-emphasize when I'm in clinic seeing them in follow-up. These are important. These are not necessarily medication therapies, but these are things that often patients ask. Things like saturated fat intake, omega-3 intake, cholesterol intake, sodium intake. How much should I exercise? What's my ideal body weight? What should my blood pressure be? And if the patient's diabetic, what to aim for there? These recommendations are all very important, and you should try to work those into your conversations with patients whenever possible. So to summarize, if we want to have the best outcomes for our MI patients, we need to do the following. We need to risk stratify them early, and remember, this is where that risk score comes into play, because it helps us with thinking about how quickly we want to proceed with invasive treatment. We need to appropriately use our antithrombotic medications as well as all of our other secondary prevention medications. We want to be very, very careful with dosing. And we need to emphasize very early on that this is a lifelong disease and that patients need to be very, very tuned in to the fact that they need to be adherent to their secondary prevention therapies as well as make lifestyle changes in response to this. Thank you very much for your attention.